afternoon. I'm delighted to be here to present this lecture, the Martine Jackson Memorial Lecture. And I'd just like to obviously do the very first important slide to declare I have no financial relationships at all to declare. I do want to mention that I only met Martine a couple of times as a junior radiographer. I was quite in awe of her, actually. But I do remember having a lovely train journey with Martine back from some radiotherapy conference somewhere many, many years ago. And all I can say is it was a lovely journey. I do want to talk about journeys today. This is what my talk is focusing on. And thank you very much for the introduction. I appreciate that I know quite a lot of you in the audience, and I also appreciate there are probably lots of you who don't know me, and I thought it was pertinent, if I'm talking about journeys, to give a little bit of a brief introduction of my journey of how I got here today. I don't mean by Trans-Pennine Express, I mean my actual journey. So I was brought up in the northeast in a little fishing village called Mask by the Sea, and this is a picture of me and my big sister sitting in a fishing boat on the beach. There's absolutely nothing really happens in Mask. The most exciting thing to do is to sit in a fishing boat on the beach. I'm not really sure how I went from being a very small fishing village to becoming a therapy radiographer. I don't quite remember the journey. I do remember going down to London with my mum to have a look around lots of departments, and we went to have a look around the London hospital, the radiotherapy department there, and I remember speaking to the staff and had a bit of a light bulb moment that, yes, this is what I actually want to do for the rest of my life. So I trained at the London hospital, and I worked there for a little while afterwards, but I did miss the beach and my family, so I tried to migrate north again. I didn't quite get back up to the northeast. I made it back to Cookridge Hospital in Leeds. I'd like to show you a picture of Cookridge Hospital, but it's not there anymore. It's been knocked down, sadly. I spent 14 years at Cookridge, and I specialised in pre-treatment imaging. I did my PhD while I was a clinical radiographer, and I only mention this because it's relevant to what I'm going to talk about. So my PhD was in the field of breast cancer radiotherapy. And I mention that because I'm going to talk about patient journeys and the importance of patient journeys, and all of my examples are on breast cancer. And I know breast cancer often gets all the publicity, all the funding, or it's perceived to be. And I apologise for that, in that I don't consider breast cancer any more important or any more pants as a cancer than any other type of cancer. It's just that that's what my PhD was in, and my postdoctoral research is in that field as well. In 2001, I joined Sheffield Hallam University as a lecturer. And this is where my office is, on the lovely Collegiate Crescent campus. And I work with a fantastic team at Sheffield Hallam, and I'm really lucky to work with them. So I became an academic, and so I'm a researcher and lecturer at Sheffield Hallam. My teaching and my research focus all around breast cancer. That's what I do. As in my introduction, I'm the chief investigator for a project called the Support for All project. We've developed a support bra for women who are undergoing radiotherapy for breast cancer. And I'm also founder and chair of the Breast Radiotherapy Interest Group. It's a special interest group for radiographers, dosimetrists, people who specialise in breast radiotherapy. And it serves as a network to support people to exchange practice and to improve service and delivery of breast radiotherapy techniques. I'm also the chief investigator for a new study called the Respire Project, which I'd like to talk about in my lecture today as well. So this talk is all about journeys. Specifically, I'd like to talk about the patient journey, and I'd like to start by talking about why understanding the patient journey is important. I'd then like to talk a little bit about how we can learn from patient journeys to improve patient care, because that's what it's all about, isn't it? That understanding what patients are going through so that we can make care and delivery of services better. And then I'd like to talk a little bit about using innovation and creativity to improve that journey. So why is it important that we understand patient journeys? Well, these are the figures that I'm sure we're all aware of. Every 2 minutes, someone in the UK is diagnosed with cancer, and 1 in 2 people will be diagnosed with cancer in their lifetime. Pretty shocking statistics, but it does mean that over half of us in this room will unfortunately experience that cancer journey. And the other half, no doubt, will be touched by that cancer journey, either through a relative or a friend. So we all have a vested interest, don't we, in terms of making that cancer journey as pleasant as it possibly can be. If we look at breast cancer specifically, we know that survival rates have improved dramatically since the 1970s, and that's absolutely fantastic. What it does mean is that the patients that are surviving now are living with the side effects of the treatments that we give, and it's important that we understand the implications of those side effects on patients' quality of life and their ability to undergo their normal activities of daily living. So my presentation is about patient journeys, and so it's prudent that I talk about patient experiences and use lots of patient quotes. Some of the quotes that I'm using today are anonymised, they're given false names, and where the patients have requested that their actual names are used, I have actually used their names. I'd like for a moment, if you would bear with me, to give one patient story, if that's okay, and I'm going to read it. I was diagnosed with stage 2B breast cancer a week after my birthday. Although I had expected the diagnosis after finding a lump, I was still devastated when I received the news, and my immediate concern was how I was going to tell my children. My son had just started a new job 80 miles away and was worried about where he was going to live, how he could afford a flat on his own, and whether he would be able to live up to the expectations of his new boss. My daughter was 10 years old, busy with school life, friends, sport, and generally being a bit of a prima donna. It felt like I was about to throw a hand grenade into their already complex lives, and I wasn't quite sure how we would cope with the fallout. My husband and I told them separately, my son first, as the oldest we thought he might be able to comfort his sister later. He cried. He was 24. I had not seen him cry since he was about 6 years old. My heart broke. I couldn't say the words, "I have cancer," so my husband did all the telling of the bad news. He did it like a pro, even though I know he didn't want to do it either. My daughter cried, and both children asked the same question. "Mum, are you going to die?" Big brothers are, for the most part, really annoying when you're 10, except when you hear your mum has cancer, and then Big Brother seems to be the one person you want to hug from most, and they shared their grief together. My husband and I faced my surgery as a team. I'd never had an anaesthetic before. Everything was new to me, so I clung to my husband throughout the whole process. It was a tortuous journey. On the day of my first operation, a last-minute ultrasound identified a second, previously undiagnosed tumour, which meant the surgeon had to think on his feet. He had to change the excision position from that previously planned, and I headed for surgery not knowing if it was the right operation to have. As it turned out, it wasn't. One emergency evacuation for a hematoma and one further tumour excision was followed finally by a mastectomy with immediate reconstruction. It had been traumatic. With each operation came weeks of waiting for pathology results, and with every appointment attendance, more bad news. Having navigated surgery, I moved on to chemotherapy. I joined a clinical trial and felt I was ready for what was about to come. I used the cold cap to try and keep my hair, but the success rates are not as good as I'd imagined they would be. And despite enduring the pain of the cold cap, it didn't work for me, and my hair fell out in lumps. I struggled to cope with the experience. My veins had given up after the second cycle of chemotherapy, and losing my hair had hit me hard. It hit my daughter harder. She just wanted me to look like other mums, and wearing a headscarf made me look different. I missed her gymnastics awards evening because she didn't want me to look different to the other mums. So I stayed at home while she went with the mum of one of her friends. I got a wig so my daughter would feel happier when I dropped her off at school, but I hated it. I started avoiding doing the after-school gymnastics pickups. as I didn't want to see anyone. It was a struggle to just get out of bed. At about the same time, the local hospital informed me that I could no longer have my chemotherapy there because I was in a trial, and I would have to travel 40 minutes to another hospital for the remaining cycles or come out of the trial, and I didn't want to do that. After my 4th cycle of chemotherapy, I had taken my daughter to school. I was feeling the usual nausea, shaking hands, and I could barely walk. On the way back to my car, I was stopped by a mum of a girl in my daughter's class at school. She informed me that our beautiful, kind little girl was in fact not so kind and was being mean to her daughter. And she told me that perhaps my daughter wasn't coping with my diagnosis as well as I thought she was. My world fell apart at that moment. I had no hair, I felt unwell, I felt vulnerable, and the chemotherapy meant I lacked the finesse in my communication skills I was used to having. So I said very little, and I left as quickly as my legs could take me back to the school, where the head teacher had to rescue me with tea and kindness. The accusations were unfounded and the situation resolved, but the experience had been traumatic for our daughter, for all of us. By the time I met the oncologist to discuss radiotherapy, I was clinically depressed. This was my journey. This is my breast cancer journey. But I don't think I'm alone in experiencing some of the negativity of that breast cancer journey and getting to the point of feeling clinically depressed. The research supports the fact that many cancer patients will suffer some experience of psychological distress, and many will have symptoms of post-traumatic stress disorder. This research highlights that around 20% of patients diagnosed with cancer will experience PTSD. If we look at breast cancer specifically, this particular study identified quite small incidents of post-traumatic stress disorder. But if you look at their data, and if you look during the radiotherapy period, the number of patients who had at least one symptom of PTSD is actually really high. It's in the 80%. So during radiotherapy and for a period after radiotherapy, over half of the women that we see are likely to be suffering some symptoms of PTSD. Again, this is a really interesting study. It's from Japan. This study identified, they got patients to complete the hospital anxiety depression score and also a radiotherapy categorical anxiety scale which they developed, which measures anxiety specific to radiotherapy. And what they found was that patients reported anxiety about adverse effects of radiotherapy, anxiety about the environment, being left alone, and anxiety about whether radiotherapy is effective. And around about 50% of patients had adjustment disorder or major depressive disorder prior to radiotherapy. And you could argue that, well, that's a study in Japan, that might not translate to the patients that we see in our radiotherapy departments, and it's a good thing to question. However, in our Support for All study, when we have spoken to patients about their experiences, they talk very similarly, actually, about fears and anxiety. They talk also a lot about technology-focused care. So these are just some of the quotes from some of the patients that we spoke to. And they talked a lot about fear. Fear of radiotherapy, fear of the side effects, and fear of moving during radiotherapy because they understand the importance of treatments being accurate. They also talked about feeling disempowered and vulnerable, and they also talked about not being in control. What it led us to believe, a lot of what patients told us about, was about this issue around technology-focused care. And we do focus a lot on technology. It's our way of caring for patients, actually, is about making sure that our treatments that we deliver are really, really accurate. But sometimes we kind of miss the human side of the patient care because we focus a little bit too much on the technology. And what I mean is if I could use this as an example, this is a really excellent piece of research that was published in 2017. It's some technology that's been developed to treat women who are having breast radiotherapy using protons. And it involves the development of a couch, and it's in a frame. And what it allows to happen during treatment is that you can twist the patient in every degree necessary to produce really accurate treatment. there's a little, this breast mould is individually made. It's made for every single patient, so it's individualised. So it fits really well. Breast is, as you can see here, is an aperture in the gown, breast is out, and a hole for the nipple is how they accurately position the machine. It's a fantastic piece of engineering. But I do wonder how much patient involvement there was in the design of this technology, because it takes, once the treatment's been given, the patient has to be soaked in a bath in order for them to get this off. And this is another example. I know that the prone technique has lots of benefits for some women, and it's designed for women with larger breasts. And I understand and I get that lying prone means that the breast separation is smaller, and that's beneficial to applying beams. But I just look at this image and I think it's so undignified, and surely there is a better way. We can do better, surely, than this. So, having identified that actually patients are likely to be suffering quite psychological distress before they even get to the radiotherapy department, I think it's really important that we take account of that in what we do and how we deliver radiotherapy. And understanding their journey is really important so that we can improve the services that we provide. But how can we listen and understand patient journeys better? Well, we can listen, and I know radiotherapy departments have got lots of really fantastic ways of getting patient feedback and using that to in the cycle to improve services. But I think we also need more innovative. I'm struggling to get this to work. Oh, there we go. More innovative ways of documenting patient stories, and also educating not just ourselves but also the general public about what it's like to have radiotherapy and to have cancer. This is, I can get it to go. This is an experience from the words of a patient who had treatment for breast cancer. Although her breast had been saved during surgery, afterwards her pain was so great that she had gone back to a surgeon and asked for a mastectomy to remove her breast altogether. Her pain was caused by breast lymphedema. If you look in the literature, or try to look in the literature for the incidence of breast lymphedema, it's quite variable in the literature. It ranges from just over 0% up to 90%. Now, if 90% of women who have a wide local excision go on to get breast lymphedema, that's a lot of women who are going to be suffering pain and distress. But the fact that there's very little literature about that side effect means that as healthcare practitioners, we don't recognise it, we don't see it, we don't understand it. And what it means to patients is that quite often they are left sometimes undiagnosed for quite some time. Janet Ullman is one of my PhD students, and she's investigating patient experiences of breast lymphedema, and she's using a participatory approach which is appropriate for this type of research. But she's also using a methodology called photo elicitation to try and understand what it's like to live with breast lymphedema. She's spoken to many women who have the condition, and what it's revealed is a substantial amount of distress and despair caused by the physical pain and the discomfort, and also the anxiety caused through a failure to get an accurate diagnosis quickly. It takes many months. And many of them have spoken about this emotional burden of having to adjust to this unexpected lifelong condition. So photo elicitation uses a method where patients are asked as part of the research to either take pictures or draw pictures or pick a picture from a stock of images that reflect their experiences and what they're going through. And this is a drawing from one of Janet's participants. And this is the narrative that goes with it. And really this patient is really explaining her frustration around the fact that it took such a long time for her to get a diagnosis. And she understands why that clinicians are focused primarily on saving lives, and patients want us to be focused on that. But it's also important for her that people understand the impact that having breast lymphedema has on her life and always will have from this point moving forwards. That she spends 40 minutes a day massaging every day as part of her treatment. This picture and this narrative from another participant explains, I think quite graphically, how lonely the journey is sometimes. And we know patients have lots of support, they have family, they have friends, they have all of the support, the healthcare practitioner team, but sometimes you do feel very lonely and that you're walking that road alone. This image from Linda really represents her sadness at developing breast lymphedema, and that she can no longer wear her really pretty, lovely lingerie that made her feel good and made her feel confident and happy, and she's had to give that up to because she has to wear a compression bra, which looks nothing like that, I can tell you. So photo elicitation is a really useful way of recording and reporting patient experiences, because when Janet comes to disseminate her results, she'll not only do her usual peer review journal articles, but she'll be able to exhibit all of those images so that patients, members of the public, can come and see and learn about patient experiences too. I'd like to just momentarily talk about this document from the College of Radiographers. I'm sure all of you have read and are using, but it is a fantastic document, and it gives lots of really useful links and tips on how to use patient voice in the development of services. So it covers aspects of service delivery, service development, education and research. And even though we've known for a long time that patient and public involvement in research is really important, I read a lot of research proposals for funding for undergraduates, postgraduates, students and PhD students, where there's no patient and public voice at all, surprisingly still. So it is a really important document, and it gives lots of links to useful and interesting methods to support the voice of the patient. Another important way of including the patient experience in what we do is the use of co-design. And co-design is a methodology. It's participatory in design. And we've used it in a number of our research projects, and it's meant that the research has taken a very different route than the one that we planned by working with patients as partners. Sorry, I'm really struggling to get this to move on. Maybe I should point it that way. So, having identified that patient stories are really important and we need to measure them, we need to record them, and different ways that we can do that, especially in research, I'd like to just start to think about how we can use all of that information to make the patient experience better. I really like this quote from Sir Ken Robinson. I think as radiographers, we sometimes are a little bit nervous about stepping outside of our comfort zone and doing things differently. And sometimes I think it's because we're a little bit worried of getting it wrong. And I would say, don't worry about getting it wrong. I've made a career of getting it wrong. So it's important. It's the only way that we can ever make things better and change things is to try something out. And I would say you've got to take a risk sometimes. You've got to have a bit of a punt and give it a go. And being creative and innovative obviously is not you. And I'm going to point this, Dr. Rachel Harris, who's sat on the front row there. This work that Rachel did was back in 1997. And it's the perfect piece of work that has stemmed from patient experience. So this was built on the fact that a patient had commented about how awful it was undressing at a chair and having to walk naked from the waist upwards from the chair to the linoleum bed. And Rachel and her colleagues developed this breast gown. And a lot of departments don't no longer do that, but it still happens because patients tell us about it in our research that it still happens. And Rachel had to take a risk at that time to design that bra. And I think what we have to do as a profession is we have to all be prepared to take a risk, either in developing new devices or techniques, but also to support our colleagues who do that, and to get on board, to give it a go. Sorry. And I put this flat slide up to sort of reinforce why it's important to give it a go. James Dyson, when he realised that his vacuum cleaner kept on getting blocked and he wanted to design a new one, it took him 5 years and over 5,000 prototypes before he developed a product that he could take to market. We're just on prototype number 5 for the Sport for All bra. I'm really hoping we don't need to go to 5,000 before we nail it. But my co-investigator on the Sport for All project reminds me of this every time we have a bit of a negative development in our pathway and we get all sad about it. It reminds us that actually we're still quite in the early stages. But as a profession, we have to accept that we're not going to solve these challenging issues overnight, and we have to keep trying, and we have to support each other and look at how we can make things better. This is the Sport for All bra. This is a patient lying on the bed. It's a surface scanned image. And what we've done with the Sport for All bra, it is a challenge. It's a massive challenge, and we have taken a big risk in an area where treatment has worked for many, many years, and yet we're going to keep going till we get it perfect, because we want to not only provide dignity and modesty, we want to be able to support improvements to dose to organs at risk as well. This picture here, it's a little bit confusing. It shows the patient, it's 2 images overlaid. The participant, is scanned naked and then scanned with the bra on. And it's really just to show how the bra works, in that it lifts the breast upwards superiorly, and it lifts it medially, gets rid of the skin folds both inferiorly and laterally. That's how the bra works. As I said, we did some co-design as part of this project, and what we found, the biggest concerns from patients was this feeling of being disempowered, lack of choice and exposure. That's skin exposure, not sort of radiation exposure, so having to be naked. The healthcare practitioners' biggest concerns were about not being able to see skin reactions if they were wearing a bra all the time, and what would happen if the breast was swelling. And so, as a result of the co-design, what we ended up developing is some patient self-monitoring tools. So we've developed some lay versions of the RTOG skin scoring system, and also a scoring system for changes in the breast that might identify when a patient is developing breast lymphedema. And this would never have happened. We would never have considered doing this if we hadn't done co-design and spoken to patients and radiographers. And actually together, we put them together, the radiographers and the patients, and this is what they came up with. The breast radiotherapy interest group I mentioned earlier is a special interest group for qualified practitioners. It's a closed community, and it was set up to facilitate and coordinate networking across organisations. In 2018, I realised that we missed the patient voice, and it's really important that it's a closed system so that radiographers and dosimetrists feel safe to be able to talk about their techniques, some of the challenges and the problems that they're having. But we did miss the patient voice. So we set up a patient-to-public arm of BRIG in 2018, and what we've been trying to do is to gather patient stories that we can feed into the professional arm so that people can learn from those stories. So if a patient reports a problem in a department, then that department will learn about that problem and change their services. But we wanted everybody to learn from that problem, not just that single department. We also surveyed BRIG members in 2018 because of the UK consensus guidelines on breast cancer radiotherapy. And those guidelines, for anybody who doesn't know, are meant to try and standardise radiotherapy for breast cancer for everybody. And they're really good. They're based on best available evidence. What we were really interested in was those consensus guidelines were given to us as a professional community. This is what we should be doing. We were interested in, well, how are people managing? Are they able to cope? Have they got the resources to be able to meet these guidelines? I'm not going to go through the whole survey, but I just want to focus on heart sparing techniques because that's quite pivotal in the consensus guidelines. And this is the response in terms of the different types of heart sparing techniques that centres use. Don't worry that these add up to more than 100 because centres do MLCs and breath hold techniques as well, so that's why it adds up to more than 100%. But what's really interesting is we asked them about what are the barriers to implementing, and we expected to see things around staff capacity and training and time pressures, etc. What I didn't expect to see was so many comments about patient-related factors, so difficulties with patients maintaining breath hold, patient compliance, and communication. At about the same time as we did that survey, I'm, like many of you, I'm on Twitter, and there was a patient who tweeted about their experience of deep inspiration breath hold and had a bit of a negative experience, and I saw the tweet, and I thought I felt duty bound to try and help. So this individual was having difficulty maintaining breath hold and had been asked to go away and practice, and I thought there must be a video somewhere that I can send her the link, and I couldn't find one that wasn't either equipment specific or just related to the process and not about coaching. So from this survey and also that patient experience, we developed a new project called the Respire Project, and we're working with our physio colleagues and with the BRIG community to develop some resources to prepare patients for deep inspiration breath hold. We're using a participatory co-design methodology to engage with stakeholders. And the aim of the project is to develop, well, initially, I thought, let's develop a nice little video that all patients can watch, they'll understand, and we'll be able to coach them a bit before they go for radiotherapy. Of course, when you talk to patients and health practitioners, it's become much bigger than that. And so what we are actually going to be doing is we've got several series of videos. And our patients told us, when we talked to them, they were talking about being relaxed for radiotherapy. And the physiotherapists have also said, well, relaxation is really important for breathing. So the first set of series of videos is going to be relaxation techniques, non-breathing related relaxation techniques, obviously, so we don't want to interfere with the breath hold. But it's really interesting that patients brought this up, and one of our patients' representatives also said, you know, it would be really great if we had some relaxation techniques that we could practice, because my husband, he wanted to help so much, and family and friends do. They want to get involved, but there's no job for them. There's nothing for them to do. But relaxation is probably something they could be involved in, and it would make them feel included. So the first series will be relaxation techniques, and then we're going to move on to a series of videos about the deep inspiration breath hold bit itself. And also the patients were really interested in the techie bit, the bit behind the scenes with the dosimetry planning, and they all said, I wish I'd seen that. That's really interesting. I would have really liked to have seen that. So we're going to explain that to them in order that for those patients who can't maintain the breath hold and have to not have breath hold, they'll feel less anxious about not being able to do it, that actually there are other things we can do with multi-leaf collimators and changing beam angles to reduce the dose to the heart. And then finally, a series of videos on patient coaching to help them get to that point of being able to maintain the breath. So this quote came up when we did our first co-design workshop with patients in the Sport for All project. And one of our patient representatives said, we all want to get to the end of treatment, all of us, that's what we're aiming for, but actually it's the journey that matters in the end. And I hope that what I've spoken about today has reinforced that for you. You'll be pleased to know we've come to the end of this journey. And I'd just like to finish by saying that thank you for listening to my journey, and I wish you all very long journeys that take you in lots of interesting directions. And if you want to contact us about our research, please do. I'd be delighted to hear from you. Thank you.